I think we're ready to start. Good evening, everyone. Welcome to today's lecture. My name is Elias Mosialos. I'm the director of LSE Health, as well as a professor of health policy in the Department of Health Policy, the London School of Economics and Political Science. It's a pleasure to host this session and to see such an impressive turnout for what promises to be an engaging and thought-provoking discussion. Our focus today is on understanding the economic burden of antimicrobial resistance, a topic of significant, of critical importance for global health policy. While the clinical and microbiological aspects of AMR have received significant attention, understanding its economic, socioeconomic implications is equally important. This knowledge enables policymakers, researchers, and healthcare systems to develop more effective strategies, allocate resources wisely, and mitigate the far-reaching impact of AMR. We're fortunate to have two distinguished experts with us this evening to share their insights. Our first speaker is Anthony McDonnell, a policy fellow with the Center for Global Development, and he is working for the Global Health Policy team. Anthony leads the center's work on AMR, including modeling its microeconomic effects. His impressive background includes serving as head of economic research for the UK's independent review into AMR, which received significant global attention. This was commissioned by the UK government and the Wellcome Trust. He also managed the Wellcome Trust project exploring funding opportunities for economic research and worked as a senior health economist at the University of Oxford, where he modeled the costs of malaria interventions. More importantly, Anthony studied at the London School of Economics. This is not the reason that we have invited you to present today, Anthony. It's because of your impressive CV. Anthony's presentation will last approximately 45 minutes. Following Anthony's talk, we will hear from Michael Anderson, a senior visiting fellow at LSE Health, and the National Institute for Health Research funded clinical lecturer at the University of Manchester. Michael's extensive research portfolio includes analyzing the socioeconomic impacts of AMR and designing incentives to encourage antibiotic development. He has also contributed to the work of several EU presidencies, including Belgium, Romania, and Sweden more recently. Michael will provide reflections on Anthony's presentation and share his own perspectives on AMR. After both presentations, we will have a 30 to 35-minute Q&A session. You are welcome to post your questions in the chat during or after the presentations. The questions will be visible to everyone, and Michael will group similar ones to ensure an efficient discussion. Both speakers will address your questions during the Q&A session. Now, without further ado, I'm delighted to invite Anthony to begin his presentation. Anthony, the floor is yours. And thank you very much for joining us today.
Not at all. Thank you so much for having me. And it is a real pleasure to be back at the LSE. Hopefully you can all see my slides. Today I'm going to talk about the economics of antimicrobial resistance, which, as Elias said, does not get as much attention always as the clinical problems with it. So first of all, to start off with, what is antimicrobial resistance? Well, microbes are tiny organisms like bacteria, viruses, fungi that can cause infections. Antimicrobials kill or stop microbes from growing. The most important of these are antibiotics, which were first used in 1941 when penicillin was synthesized and used to try and treat a police officer, Alexander Arnold. And in this talk, I will focus primarily on antibiotic resistance. That is because it is the biggest problem of them all at the moment. There are similar problems with antifungal resistance and, to a lesser extent, problems with resistance with parasites and viruses. So antibiotics have greatly reduced death from infection. If you go back to 1900, for every 100,000 people in the US, 800 of them were dying from an infection. By the 1930s, mostly due to vaccines and infection control, that had fallen to about 300 deaths. And by the 1980s, that had fallen up by eightfold again to 36 deaths per 100,000. In the UK, went from almost half the deaths were infectious disease in 1850, about a third by 1900, down to about 7% of deaths today in the UK are infectious disease. So that rose to about 20% during COVID. And antibiotics not only treat people directly from illnesses, but they also provide a safety net within our health system. There are lots of things we do, particularly surgery, but transplants and oncology care, where we either risk an infection by, say, opening a wound, or we suppress people's immune system as a side effect to a treatment, which would not be nearly as possible, or in many cases wouldn't be possible, in a world where we did not have antibiotics to come in and protect patients when they became sick and unwell, which is part, but far from the only reason that you've had this huge expansion of surgeries in the last 70 years. So like water, they allow our health system to thrive, and our whole infrastructure is based around them as a safety net. However, within antibiotics, there is a problem of resistance. It is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. Alexander Fleming said that at his Nobel Prize address in 1945 when he won the award for discovering penicillin. And you can see on this kind of several pictures of a Petri dish how antimicrobial resistance can work. This is the same Petri dish at different time points, but in the very bottom of the Petri dish, there's no antibiotics. And then the next fifth, there's 3 times as many antibiotics as you need to kill bacteria. And then it rises to 30 times and then 300 times. And then at the end, it's 3,000 times as much antibiotics as are needed to kill bacteria. And you'll see after 44 hours, the bacteria have completely swamped the antibiotic-free area. 44 hours later, they are more than colonized the next section. And as time goes on, in 246 hours, which is 11 days, they've slowly crept forward so that they can conquer every section of the Petri dish because they have evolved to become essentially immune to this antibiotic. And as I mentioned, for almost as long as we've known about antibiotics, we've known about resistance, and economic failures undermine that, this system, which I will go on to talk about. But to just give you a sense of the scale, there is 13.7 million deaths globally from sepsis in 2019. Of these, almost 9 million are bacterial caused sepsis, which is the totality of bacterial deaths. About 5 of these 8.8 million infections are resistant to antibiotics, and it is estimated that 1.27 million are directly due to antibiotic resistance. The other deaths, people have resistant infections, but they are either of an age profile or in a part of the world where they wouldn't get access to antibiotics. And so the resistant infection is not what causes their death. And so there are several problems underpinning these. First of all, antibiotics are a common pool problem, which so our stock of effective antibiotics is a finite resource, which there's no effective mechanism to moderate in demand. And this can result in a tragedy of the commons. I suspect many of you are already familiar with the idea, but just like overfishing, people don't have an incentive to stop because each fisherman or woman gains benefit when they catch fish, and society, we suffer from the lack of fish to catch. And the same is if I use an antibiotic, I gain the benefit, but there's a societal cost from the increase of resistance. And in a paper I wrote with several colleagues, named at the bottom here, we kind of broke the pipeline down into several parts. First of all, why is there not enough new antibiotics coming out? And then secondly, why are we losing what we call the pool of antibiotics that we have due to resistance? So there's inefficient funding for research. There's not enough antibiotic incentives, in academia, often to do this research because the research techniques haven't changed hugely since the 1920s, 30s, and 40s. And so it's not seen as innovative as something like genomics. There are real logistical challenges with running trials for bacterial infections because you've got to get somebody onto a treatment incredibly quickly. And so you can't really move them. And there's also the problem that we've got really good placebos if somebody has a drug-susceptible infection. And so you can't run a placebo study because that would be unethical and lethal probably for half the patients in the trial. And then there's a limited market for new antibiotics. Because we're trying to protect antibiotics from overuse, the volume of sales for new drugs is not very high in the early years. And also, because there are often substitutes, however imperfect, people can be tempted to put somebody on the wrong antibiotic if it's much cheaper. And so that leads people to move away from the best course of treatment, and that can keep the price down. Similarly, we use the antibiotics we have because overuse, because we treat too many people. If we had better infection control, we can stop people getting sick. And if we can stop people getting sick, they don't need antibiotics. Inappropriate use, we either give people the wrong antibiotics or we give people who don't need antibiotics. For example, about 30% of antibiotics in the UK are handed out for the cold and flu, which are viral infections, which antibiotics, except in very rare cases, are going to provide no benefit for. And the UK is better than most countries in Europe at reducing unnecessary use, but yet still almost a third of antibiotics are just on one disease area. Then there's environmental dumping of antibiotics into rivers. This comes particularly from manufacturing of new antibiotics and inappropriate use in agriculture. About 70% of the human important antibiotics in the world are estimated to be used in animals rather than humans. Now, the risk for using an antibiotic in animals is lower than in humans because the bacteria that they have are often quite different. So it's not 70% of the harm, but it is still a major contributor. And also it leads to environmental runoff, which causes pollution. So to break these down and look at it from a more economic perspective, as mentioned, antibiotics are, well, they're public goods as well as being common pool resources. They're not rivalrous and they're not excludable. If somebody, once they're generic, if somebody uses an antibiotic somewhere else, that does not stop my ability to use an antibiotic. And so it's quite hard to control. The social and private value of new antibiotics are poorly aligned. Essentially, there's a wide societal benefit to making sure that we have a sufficient line of antibiotics, but as I mentioned, the payments are not quite there. Regulatory failures often exacerbate market failures. Particularly, it's difficult to pass a new product when you can't test on patients with resistant infections very easily because they're hard to find and often there's not very many of them. And we want these antibiotics approved when resistance happens. So they use something called non-inferiority trials, which is to try and show that a new product is no worse than the placebo. But this is statistically quite challenging and also regulatorily difficult. And then antibiotics have an insurance value that we do not pay for. So we at any time, a new resistant infection can come along and they're quite random and hard to predict, or a previously not very prevalent resistant strain can become very common. And we want antibiotics there ready to use if that happens. However, the way we fund drug R&D is that we pay normally about 10, 12 years of patented sales. And so if somebody comes up with an antibiotic and sales are very low in the short term, but in 15, 20 years' time, there's a crisis and we need that antibiotic very badly, that innovator does not get very well paid for that because it'll be out of patent. And while that in the short term is probably great for society that we don't have to pay very much for those drugs, it stops people making those investments. Instead, we probably want an insurance value because we never know when we might need a certain type of drug. And so we should pay to have it there in case we use it, which is how the UK has moved to purchasing antibiotics. But sadly, most other countries have not followed, and the UK is very much a leader in the space. And then finally, and maybe the biggest problem of the pipeline is that there's huge access problems. Most antibiotics only get registered in the US and maybe a handful of other high-income countries. Even Europe and Canada and Japan, often the market is so small that it is not worth companies trying to deliver them. And this means that people who need antibiotics the most do not have access to new drugs. Then finally, secondly, there's overuse problems. There is 4 things causing this. Infection control is a public good. Like, people wash their hands. Often the people who benefit most are not the person washing their hands, but it's everybody else. They also require huge amounts of infrastructure. Unless you are incredibly wealthy, you are not going to be able to build a sewage system to your house. You're not going to be able to build piped water into your house. And so we rely on states to come together and generate the infrastructure that we need. And often this isn't a high enough priority. Secondly, there's a mismatching problem. Often we are not good at aligning the people who need an antibiotic with the antibiotic that they need. And this can be improved through better diagnostics. So we then know what antibiotic a person needs best, and we know whether or not somebody needs an antibiotic. But at the moment, those two things are not aligned, as discussed. And then there's negative externalities, both for use in pollution and agriculture. It often costs very little to deactivate active pharmaceutical ingredients before they're dumped into water systems. But when regulation doesn't exist, encouraging or forcing companies to do this, or when it is not enforced, then cheaper than very little is free, and there is no cost to not deactivating these ingredients. Similarly, with antibiotic use in agriculture, it probably varies on the country, but evidence from the US and Denmark suggests that it might only cost 1-2% more to reduce antibiotic use in agriculture. But any one farmer does this is at a disadvantage unless they can convince people to pay more for those products. And so even though at a societal perspective, it might make sense to spend 2% more on meat so that we don't have as much resistance and antibiotic use in agriculture, it is not. Individual farmers aren't incentivized to do this. So more recently, at CGD, we've been working on a project to understand the economic impact of antimicrobial resistance. And that's what I'm going to spend the rest of my lecture discussing. I should start off by saying this work was done as part of a consortium that included the World Bank, who peer-reviewed the work, the World Organization for Animal Health, the Institute of Health Metrics and Evaluation, and RAND Corporation. And the World Organization for Animal Health and RAND did a study looking at the antibiotic use in agriculture and how to reduce it. IHME took estimates that already existed on the current burden, that they had created on the burden of antimicrobial resistance, and they projected those forward to the future to understand what might happen in 2050. IHME also came up with the numbers I used earlier to outline what the problem is. And then at CGD, we led work on understanding the economic burden of resistance in human health. So what is the economic cost for resistance going up to humans? So quickly to summarize IHME's work and methodology, they first of all worked out what the resistance rates and deaths from bacterial infections are between 1990 and 2021. And then they projected those trends forward to 2050. So what if resistance continues to grow at the rate it has? They then adjusted this for demographic changes. So if a country is going to get far older, then you're going to see, and old people are more likely to die of resistant infections, which they are, then as the country gets older, you're also going to see a spike. If a country, and I'm not aware of any, but if a country was getting younger, or having less people over 65, then you would see the opposite happen, even as resistance rate goes forward. And then they also generated a lot of different scenarios, which I'll show in the next slide, for what could happen in the future. They expect the percentage of bacterial infections that are resistant to increase, which has been happening for quite a while now, but they also expect a reduction in the total number of bacterial infections as there are more vaccines, better quality sanitation and water systems, and better access to good health care. And that this will lead to more old people getting sick and dying from drug-resistant infections, but also a reduction in children. If you look at under 5s who die from drug-resistant infection, they are very few in high-income countries. And they're almost all in LMICs, and those in LMICs, about half are in sub-Saharan Africa. And as countries get wealthier, the children are born and grow up in cleaner environments, and so they're less likely to get sick, and they also get access to better healthcare. And then, as mentioned, they used various scenarios. The business as usual one is just if resistance follows historical trends. They also look at what happens if there's a better treatment to bacterial infections, and in this they looked at if all countries could treat bacterial infections as well as a country in the 85th percentile for good treatment, what would that look like? A third scenario looked at what happens if we can roll out a sufficient number of gram-negative antibiotics. All bacteria are either gram-negative or gram-positive. Gram-negative antibacteria are harder to treat, and they account for about 2/3 of deaths at the moment. And so they're generally seen as the priority in terms of new drugs. The fourth scenario combines these two things. And in the fifth one, they combine these two things, but they also look at what would happen if there's improved access to vaccination, sanitation, and clean water. And then finally, there was an accelerated rise in resistance scenario, which looked at what would happen if, instead of rising at the average rate for all countries between 1990 and 2021, each country rose at the 15th percentile, so the worst, the bottom end, did in that period. What would death rates look like? So we took this health work and we modeled. We built several models ourselves, which I will go through the workings of and the results in more detail. A health cost model, which looked at what is the cost to health systems of a rise in antimicrobial resistance. We then looked at other parts of the economy through economic resilience. And so what would happen to tourism, trade, the labor market if people leave? We took the results of these two, went into a macroeconomic model, which looked at how the economy might change as a whole. And then finally, we looked at an intervention cost model, which looked at how the interventions that were outlined in the various scenarios, how much it would cost to roll some of these out, and thus the return on investment. So I should say also the health cost model work was led by another LSE alumni, Tim Lawrence, who is a brilliant young, or not even young anymore, brilliant researcher who was at a master's in health, I believe, at LSE. So the first part of this model estimate what is the cost per inpatient admission of a drug-resistant infection. And we took 234 studies and find 911 data points of a different infection and what it costs if it is drug-resistant and drug-susceptible. We then did a similar, smaller literature review to look at, then we did a modeling exercise to try and extrapolate from this what is the expected cost across the whole world, because there wasn't a study on every country and there wasn't a study on every country with every resistance type, and also sometimes there was 2 or 3 studies from the same country and they differed from each other. So this allowed us to estimate the cost per country. Then the next thing that we needed to look at is how many people are being hospitalized in every country, because the greater the level of hospitalization, the greater the cost. And actually the link between the evidence of total incidence of antibiotic resistance isn't very high. We've got a much better sense of the number of deaths from antimicrobial resistance. So we had to work back from that. And then finally, we put these together where we had estimates for the number of infections and estimate for the cost per infection to come up with an estimate for total cost. And then we projected these forward based on IHME's work, also projecting forward different costs. This graph takes a range of different infections, and it's a log scale, and looks at what is the estimated cost of admission for a resistant infection. And one thing you'll note is that the scale changes, and the cost is much, much higher in a high-income country than it is in a low-income country, and middle income and upper middle income get steadily more expensive as well. And TB is by far the most expensive to treat, and diarrheal diseases are the cheapest. I didn't mean to go backwards there. And so we also looked at what is the increase in cost that is due to resistance, because in a way, what matters here is the excess resistant cost. Because if we had a magic wand and we could get rid of resistance, but not bacterial infections as a whole, we would still have to treat all of these susceptible infections. Drug-resistant TB costs about 10 times more to treat than drug-susceptible TB. For every other disease, it's about double, but it depends on the cost, on the disease, on the country. And so in low-income and lower middle-income countries particularly, you see a much greater increase than in high-income countries. I think there is a fruitful area of research here because we weren't expecting this, but our understanding of what's happening is that the quality of care and hospital care for patients with infections is very high in high-income countries anyway, while particularly in middle-income countries, patients can be moved to ICUs, and you can see a greater step up in care compared to the baseline when people have resistant infections. And that leads to a relatively higher cost, though, as you'll see from the numbers, the absolute increase is still much higher in high-income countries. We tried to estimate the proportion of hospitalization admissions that are due to drug-resistant infections. They account for about 7.5% in low-income countries, and this comes down to about 3% in high-income countries. But as you'll see from the box dot plot, this varies a lot, and you do get some outliers. Countries like Pakistan and Syria do not behave the same as everybody else because of either political problems in Syria or quite high rates of resistance in Pakistan. So the total cost of treating people in hospital with drug-resistant infections, we estimate, is $150 billion. And about 66 billion of this is caused directly by resistance, which is the difference between if all costs were susceptible. And if we followed historical trends, that 66 billion we'd expect would rise to 159 billion in 2050. This is using 2022 dollars. And the main driver of that cost is that as middle-income countries are expected to become much wealthier, the amount of money they spend on healthcare will go up. And so the cost burden of resistance will become higher for them. And you'll see it's fairly stable in high-income countries. And it actually increases a lot in low-income countries, but they're so small that they do not drive global picture. So small economically, I should say. And so if we go back to the scenarios I outlined earlier, we can also show that it saves money for healthcare systems to roll out those different scenarios. And so we will spend 19 million less on health if there's better treatment, though this would probably be dwarfed by the increased cost of the better treatment. Across the world, $83 million will be saved from innovation, 97 million by better treatment and innovation. And if we combine everything, it would save about $100 million a year. In the accelerated increase in antimicrobial resistance scenario, you see almost $200 million of extra health expenditure coming from a rise in resistance. So the next, the macroeconomic impacts. And first, as I mentioned, we did a resilience model, as we called it, and tried to work out what changes there would be to different factors of the economy because of resistance. We expect the labor population to fall, though only to fall by about 1/5 as much as the overall population decline. And the reason for that is the two groups that are most likely to die from resistant infections are over 65s, who vast majority of whom are retired, or under 5s who have not yet entered the workforce. And we only model to 2050. And so you do, at the last kind of 5 years of our modeling, see an increase or a fall in labor force participation as children who otherwise would have entered the labor force don't reach it. If we were modeling in a larger time horizon, you would see a much greater impact on the labor force due to young people dying. Morbidity is quite small for antimicrobial resistance and its impact on the labor force. The reason for that is that most resistant infections, people either recover quite quickly or they die. So in IHME's estimates, about 2% of the DALYs lost through AMR are lost through morbidity, and 98% through mortality. And that is, I'm not aware of another illness which is so heavily skewed towards death driving the burden. I'm sure there are some, but it's unusual. And that's because either the antibiotic work and you'll hopefully get better quite quickly, or they don't work, in which case you have a problem. And if that problem is you're only sick for a few weeks, that's not really huge on the whole scale of a lifetime. But if the problem doesn't fix in a few weeks, you're probably not, or you're likely, a large chance you might not make it. We originally looked at care responsibilities to people looking after those who are sick, but this is close to 0 because morbidity is quite low. And looking at literature that exists on care responsibilities, they tend to be quite large for very long-term illnesses, where people have to take a lot of time off work to look after a disabled relative. But when it's quite a short illness, people are able to take sick leave or annual leave or move things around, and you don't see a big consequence of that. And then finally, we looked a little bit at bereavement and what is the impact on friends and family through either absenteeism or presenteeism. Absenteeism is people missing work because they are sick, because they are grieving. That tends to be a much smaller impact on the economy than presenteeism, which is that people show up to work, but they don't really work very hard because their mind is focused on their loved one. This wasn't a huge driver of results either, but we did look at it. And then finally, we used expert elicitation to look at other parts of the economy and how these might be impacted. So this is a graph where we spoke to 21 experts and we asked them how much indirect labor, which is people not going to work because they fear getting a drug-resistant infection, tourism, and hospitality would be impacted by an 8-fold increase in resistance. We actually asked them about several different levels, but this is the one in this graph. And we split tourism into typical tourism, which is that every country gets worse at the same time, and outlier tourism, which is that if one country gets worse, but others stay the same. And the rationale for that is there might be a world where if resistance gets worse everywhere, you still want to go on holidays. But if resistance gets far worse in Italy, but France stays the same, or vice versa, then you switch your Italian holiday to France because you don't want to get sick. And we used we asked experts about various points, and this is just the tourism non-outlier version. Each line represents a model that was fitted to the 8 results an expert gave us to what they thought would happen. So I realize this isn't very clear. And the dark line shows kind of the average of all experts. And so they're saying that if you halved resistance, you'd see about a 4% increase in global tourism. And if you doubled resistance, you would see about a 5-6% decline in tourism across the whole world, which in absolute terms is quite small. But tourism is a very large part of the global economy, as we'll come to see. Finally, we asked experts about how different parts of the economy might be impacted, or different countries might be impacted more or less by resistance. Essentially, how resilient are they to these shocks? We didn't ask about specific countries, but we asked about characteristics. We framed it in such a way where we didn't push people towards some things being good or bad. But generally what we found was that wealthy countries were thought to be more resilient on a range of characteristics. People thought wealth in itself would make countries more resilient. Good healthcare systems would make countries more resilient, particularly for tourism. If the world gets, if there's an illness, people are more likely to go somewhere where they know they can get access to a healthcare system if they pick something up. And stronger state capacity was generally thought to be a good thing. This is an aggregate of the resilience for the 3 areas of labor, tourism, and hospitality, but we actually researched it from each one. And the most resilient country of those in our model was Australia, and the least resilient one was thought to be Nigeria, based on these inputs. I should also say we only modeled 122 countries due to data constraints. And so then put this into a GTAP model, which was run by another researcher, Amanda Countryman, who is based at the University of Colorado, to understand if you change various components of the economy, such as tourism goes down or health spending goes up, what happens to the macro economy as a whole? And we find what the results from this suggest is that by 2050, compared to the baseline, which is that resistance increases as we'd expect it to, the world is $270 billion wealthier because of better treatment, rising to 260 billion for better treatment and innovation, and almost $1 trillion per year wealthier. The combination, in contrast, in an accelerated rise of antimicrobial resistance scenario, the global economy is about $2.7 trillion poorer. These numbers are different to previous studies by the World Bank and the AMR review, which looked at a world where there was no antimicrobial resistance. And so the worst case scenario numbers are higher, but partly because we wanted to show the benefit of intervention, and a no AMR scenario is not really very realistic. We looked at a kind of a baseline comparison. The burden will fall particularly hard on poorest countries. So the darker bar on the left here shows the percentage impact on GDP, and the bar on the right shows the nominal impact. And the nominal impact is quite similar for lower middle, upper middle, and high-income countries as a collective, but high-income countries are a much larger economy than either of the other two groups. And so percentage-wise aren't impacted as much by this change. But broadly, you're talking almost 1% of the economy impacted in lower middle income countries, and about 0.5% of the global economy as a whole contraction compared to the baseline. And that's, sorry, I should have said, this is the benefit of rolling out better access to antibiotics and health treatment alongside better innovation. And then the last thing we costed a benefit was there's also just a health benefit to new treatments. And so people not getting sick is a good in and of itself. And NHS will pay for people to get well just because the UK government wants people to get well. And the UK is not unusual by that at all. And so if each country is willing to pay 1% of its GDP per capita on stopping drug-resistant infections, then that creates another roughly $600 billion a year that would be countries would be willing to pay in 2050 to get the improved access scenario to both, the improved access to healthcare and the innovation scenario, alongside the macroeconomic benefits and the health reduction costs. And that combined benefits of those three things works out at about $1.67 trillion. As well as this, as I mentioned, we did a rolling out cost model, which I didn't think I'd have time to include, but I'm just realizing I have 10 minutes left, so I probably could have. This was also done by Tim Lawrence, or led by Tim Lawrence, where we looked at the cost of rolling out better access to healthcare treatments using a quite innovative quite innovative, I'm blanking on the name of it, function to see what it would cost to raise the standard of both health inputs and in both quality and quantity terms to get to the 85th percentile, Cobb-Douglas function. Then we also looked at the cost of rolling out vaccines, new antibiotics and the investment needed to generate them, and of infection control. And those were based on predominantly based on existing research and combining them. If you would like to know more about the research, we've got a paper out on which came out in September, forecasting the fallout of antimicrobial resistance. We've also got more detailed papers coming out next week on the health cost, innovation cost, and macroeconomics. And finally, I want to thank my many co-authors in this project. I did not do this alone. I should also say, or my comments will want to say, that we also have an event launching those papers next week where we will bring in Dame Sally Davis, Tim and Amanda to discuss those and the methodologies behind them. Thank you very much. Michael, over to you, I think, or back to you, Alice.
Yeah, thank you for that presentation, Anthony. It's really useful to see, how you approach this mammoth task of estimating the economic impact of AMR. So we clearly wasn't just one study; it was several studies, brought together. So my initial reflections are that this exercise, it really represents a step change in our understanding of the economic impact of AMR for several reasons. So first, because you managed to bring together a broad range of evidence on healthcare costs from both high-income countries and low middle-income countries. And second, because you've projected forward AMR over the next 25 years based on the best and most recently available global data we have, specifically from the Graham study. And third, because you invested in intensive efforts to consider a broad range of indirect impacts of AMR. So such as tourism, trade, and labour productivity. So thinking about the next steps, so I'm now eager to see civil society, academics, policymakers, and other engaged stakeholders use this evidence to promote global collective action to address AMR. But I think we also need to reflect on one of the main findings of this project, which is that the health and economic impact of AMR is disproportionately experienced in low and middle income countries. And people that may be attending, that may go to some of the meetings run by multilateral initiatives focused on AMR will see that the people with the loudest voice in the room tend to be from G7 countries. And this often means that there's kind of a lack of understanding of the specific context in low and middle income countries and the challenges they face in developing sustainable policies to tackle AMR. So I'm really hoping the findings of this work will encourage discussion on what appropriate mechanisms exist to increase the voice and participation of low and middle income countries in these multilateral global initiatives to address AMR.
Okay, thank you very much, Michael, for your thoughtful insights. Anthony, would you like to briefly respond to Michael's remarks, or shall we move directly to the Q&A session?
Oh, just to say thank you very much. That's very kind of you to say. I'm glad you like the work.
Thank you. Okay, we'll start the Q&A session now, but we'll start with a couple of questions from Michael now, and then we'll take questions from the Q&A session. You can both access the Q&A session, as all participants can do the same, and we'll start picking up questions from the Q&A session after Michael has asked his questions. Michael, go ahead.
Thank you, Liz. Yeah, so there's a number of questions in the chat that we will go through. I just had a couple of questions I wanted to put to Anthony. So, from a methodological perspective, thinking about the inputs into your model, which components had the strongest evidence and which had the weaker evidence, and how did you overcome challenges associated with some of the more challenging inputs? And then, I guess possibly related to this, how are you planning to build on this modeling exercise in the future?
So I think the health stuff has this strong, well, the two things as strong as evidence are the health costs, where there is a huge number of papers. What we've done, I think, is very unusual. It's as far as I'm aware, the first one to come up with country level estimates and to combine the hundreds of studies that exist. But the hundreds of studies do exist for the cost of AMR. And with labor force, it's quite simple that when people die, they leave the labor market, and there's nothing profound about that. And so, it's not the hardest modeling technique to take those out of the economy. I think where it becomes trickier then is what is the question around tourism, around domestic hospitality, as we call it, which is people going out to restaurants, and on whether people will stop working because of fear of resistance. And there isn't strong literature on this point on antimicrobial resistance, in part because we're looking to the future where resistance might get worse, and we haven't lived that scenario. We actually chose those specific things based on kind of a wider literature review to what happens in other areas. And what you find generally is when there's a new infection, there's a huge, steep decline in economic activity in the very early days because people are scared. And we all remember March and April 2020, and there was a lot less travel than there was in December 2020, even though the impact on terms of health terms was much worse in January 2020, but 10 times as many people flew in the US. The lockdown wasn't as well adhered to in the UK. And that is not an unusual pattern. And so when we're looking over 30 or 25 years, what base will things return to is quite hard to tell. And so we did our best with experts, but I would love somebody to do a more detailed study on this. I should also say it's quite hard. These are often quite small changes over quite a long time horizon. And so even if we had good data from them, econometric tools that we have are quite poor at pulling out, a 2% change. It's very plausible that tourism rates never get back to what they would have been without COVID. I think 2023 was the first year where we came close to being back to where they were in 2019. And they would have been much higher in 2023 had it not been for COVID, because they've been increasing steadily every year. But we'll never know whether they fully get back to where they would have been, and that makes it quite challenging from our perspective, where a small change actually has a huge cost.
That's great. Yeah, that's great to understand. Sorry, Elias.
You have more questions, so we take some questions from the audience?
We've got lots of questions in the chat, so I think we should move on to those. So
let's move on to those. Yeah. So there is. Yeah, please go ahead. Yeah.
Oh, I've been trying to group together these questions, but they're across a diverse range of different points. So I think let's see how we go. But I'll go through. I'll prioritize the order in which they were asked. So we have a question from Robert Yates on inappropriate prescriptions contributing to AMR. So which was mentioned in Anthony's presentation. So he asks, how important is the problem of people simply buying antibiotics over the counter in countries that lack universal health coverage or with weaker healthcare systems? And he points to a study in the Lancet that says this is a potential problem in South Asia. So he just wondered your thoughts on that particular issue.
There is another question from Kirsten related to this, that it's not always poor regulation of pharmacies, but rather lack of doctors. So this is claimed to be the case in India. And there is a third scenario as well you could consider, particularly some Middle East countries with immigrant populations who work in precarious jobs. And when people feel uncomfortable with an infection, but could be a flu as well, could be a viral infection, they may put pressure on doctors to prescribe antibiotics because they're afraid of losing their jobs. So that might be another explanation as well. You may have doctors in place, but patients are asking them to prescribe antibiotics because they're afraid that they may be kicked out from the country, for example.
So firstly, I don't work on it as much or at all really, but I fully share, Rob, your dream of a universal health across the world. And I think it would improve antibiotic use tremendously because people would be seen by a medical professional, and so they're less likely to get an antibiotic that they don't need, and they're more likely to get the right antibiotic. You can't easily stop the pharmaceutical, as another comment said in the chat. You can't easily stop the unnecessary use, because at the moment far more people die from lack of access to antibiotics than die because of antibiotic resistance. And in a world where the doctors and the health infrastructure doesn't exist, we don't want to be cutting people off from antibiotics. If you're in rural Malawi, it's probably going to be a while before you've got well-stocked doctors to hand that people can reasonably get to. And so a pharmacy is likely to be their best choice for some time. And so I think we've got to be careful about what that balance is. There are many countries where we probably could regulate pharmacies better, or the real problem is lack of not that the regulation doesn't exist on paper, but that many countries don't enforce the regulation very well at all. And then, as mentioned, there's, I'm not familiar with the Middle East, but there's many incentive problems across the world. So many parts of the world, doctors get a percentage cut of antibiotics that are prescribed, or they're pressured by hospitals to prescribe antibiotics. And so that can lead to greater use. I'm from Ireland, where GPs are, for the most part, are paid by patients, and so they operate more like small businesses. And so it's very difficult for a doctor to say no to somebody because they don't want that person to abandon them and go work elsewhere. And so compared to the NHS, it's a challenge, which I guess would be another argument for universal health coverage, though Ireland has it of sorts. So yeah, there are a lot of challenges to this, but UHC can play an important role. The last thing I'll say is better diagnostics would also play an important role. So it's not just that the health infrastructure doesn't exist. The tools to equip health professionals with also isn't very good, even in high-income countries. And it's very hard to empirically make a decision about whether and which antibiotic somebody needs.
Thank you, Anthony. So we move on, Michael, with
so there's an interesting question here about the technical approaches you'd recommend to measure the impact of AMR in ambulatory settings. So you know, as a GP, I've always wondered this because you know, even in countries with quite strong surveillance systems, they're just not picking up the burden of AMR in the community, because a lot of the time we don't really send swabs necessarily, and you know, a lot of community, you know, acquired resistant infections aren't necessarily picked up.
It's a really good question. I mean, it's more of an epidemiological question in a way, which is going to be my get out of jail free card. But few countries collect substantial data here, and that's partly because it's a little bit tricky to do, but it's also in large part because this area is not prioritized enough. And you know, one thing to look at is the UK during COVID, where there were a very large number of people who were tested for COVID twice a week to give a sense of what COVID-19 rates were like in the general population. And actually that drove not just a lot of UK policy, but policy around the world, because the UK was probably the only country where you had a really good idea of what was happening in the community, which is very useful everywhere, particularly in Europe. Whether a study like that makes sense, I'm not sure, but it's certainly an area that's under prioritized, and it would be really useful to get a better sense of resistance in the community. And make modeling this issue much easier as well.
And just moving on, because I'm conscious of time. So Warren asks quite an interesting question that I'm sure other people may be thinking as well. And you're obviously the most qualified person to answer this question, considering you were involved in the economic modelling for the O'Neill report. So, you know, how do the results compare from the two exercises, and you know, what are the kind of main differences in terms of their methodological approaches?
So, and they're quite different studies in a way. So they use well, I say we because I let that work as well. But on the review, we used a total factor productivity model, which is a simpler modeling technique. That study was done before there was good health information. So until 2022, there was a really poor understanding of how many people died in the world at the time of antimicrobial resistance. And that was so on the review, we had to infer what it was likely to be like. The results aren't hugely different. I can't remember the quantum off the top of my head, but the reviews numbers were higher. There are several reasons for that. One, in 2015, 2014 even, there was a lot more optimistic about the scale of the economy was going to be in 2050 than we are today. There was a sense that we'd bounce out of the financial crisis and then the economy would start soaring again. And nobody really sees that now. And so the same percentage change in dollar terms is much smaller today, about $100 trillion smaller. So economic projections, $100 trillion smaller for 2050 now than they were back then. And to put that in perspective, the global economy is about $100 trillion. So so that changes the output. And then the review was comparing to no resistance, which it was really useful, I think, I hope, in terms of putting resistance on the map to show the scale of the problem. What we've tried to do with this study is instead show, well, what are policy solutions and how much impact can those policy solutions have, which comes up with a smaller number, because you're never going to reduce resistance to zero. But it does give us kind of a way of trying to go and speak to policymakers about specific tasks.
Thank you for that. So we have a question from Herman Garden around antibiotics as a public good. So you know, you described how that means they're available to the public on a non-excludable and non-rivalrous basis. So they were asking about, you know, how does this view align with some of the access issues that we've been talking about, you know, particularly in LMICs?
So I guess what I meant as a public good is that antibiotic resistance to an antibiotic is not in isolation. So there's what's called cross resistance. But if you come up with an antibiotic and bacteria become resistant to that, then somebody else comes up with a similar antibiotic. People were resistant to that as well. And there are essentially 5 mechanisms of action, broad mechanisms of action that all antibiotics work on. And we haven't found the 6th one in a very long time, and we're not likely to. And so one of them is to attack the cell wall. One of them is to stop them procreating. One of them is to break down DNA. One of them is to break down RNA. And I knew I shouldn't have started because I can't remember the 5th. But if say an antibiotic breaks down the cell wall, our response to that was bacteria will then grow a thicker, stronger cell wall, and that will stave off the next antibiotic that comes on and attacks the cell wall as well. And so we have and then they come off patent, and so in the same way that all knowledge is a public good, it goes in the ether. But there's nothing to stop people just generating and selling more antibiotics in a kind of a public good sense, which undermines the globally achieved efficacy.
And we've got 3 questions all around kind of antibiotic research and development incentives. So I think I might throw all 3 of them at your way at once, because I suspect that you'll be able to answer them collectively. So we've got Michael Borowitz from the UK HSA, who asks the important question, why has no other country chosen to follow the UK in terms of paying for antibiotics by subscription? And then we have another from an anonymous guest saying, has any research been conducted to identify what is the economically justifiable price that countries should be willing to pay for innovative medicines? Or I think they've said innovative medicine generally, but I think you can answer this in the context of antibiotics. And then there's another question regarding, is there an appetite from the pharma industry to really tackle the AMR challenge? So what do you think is the best approach to incentivize the development of novel antibiotics?
Okay, these are 3 really good questions. So the UK is still fairly early on in its rollout of its system, and I think there's an extent to which countries will hopefully follow on. The 2 areas that are countries that are most interesting, or I guess one country, is the United States and the European Union, where in both systems there is broad support for the idea, but it is not, particularly in the US, it's just not a huge priority. But there's bipartisan support in Congress. My understanding is it came fairly close to passing in 2022 at the end of that Congress. But it's not a high enough priority for people to drive it forward. And we're unfortunate enough that both the European Union and the United States have very complicated political structures where it's very difficult to get things through, much more so than it is in somewhere like the United Kingdom. Italy, Japan, Canada, Sweden are all doing some things on their own as well. These tend to be quite small. But more generally, there is just there's a bit of a political, there's a collective action problem here, which is that it's in every country's interest for some other country to solve it. And the UK has made, along with Sweden, have made AMR one of the big things they push for on the global stage. So that makes the politics much easier, and other countries haven't done that so much. But I'm optimistic that over the course of the next few years, that particularly the European Union might do something, and who knows what a future US Congress and president will look like, but it's an idea that has not gone away there. In terms of economically justifiable price, the main research on this has tried to focus on how big an incentive would need to be to generate new antibiotics. That's how the UK approached the question. And then the UK pays what it thinks what its share of high-income country economies are. So the overall price is about, I think it's $3 billion, a little over $3 billion for a new drug. The UK will pay up to £200 million over 10 years for an innovative drug, and that is seen as the UK's fair share. That $3 billion sounds like a lot, but it's about it would be $300 million a year because drugs are on sale for about 10 years. I tried to find out how does that compare to other drugs on the market. You can only get sales figures, or I could only find sales figures for the top selling 250 drugs in the world. But the 250th best selling drug in the world sells 2.5 times more than that a year. Sells about $750 million a year. So these are quite small sums. And in terms of pharma getting involved, it's difficult. A lot of the research at the moment takes place due to very small biotechs. And that's not just in AMR, but it's probably particularly true of AMR, where lots of innovation happens at smaller companies. It's very difficult for those companies to fundraise to do things if there isn't a market system in place. For larger companies too, ultimately they're not charities. I think there's probably a willingness to fund this, even if you get an incentive system that is, 40% as good as the 250th best-selling drug in the world, which shows that they're not only out there for profit, because the profits wouldn't be huge from this, but they tend to not be willing to do this as a large loss-making venture. That's a difficult thing for them to explain to their investors, or for whatever. I've never worked in industry, but for their decision-making processes don't allow that. And so I think we probably do need some kind of improved market to get the innovation that we need.
Thank you, Anthony. Michael, based on your recent work, would you like to comment on the Swedish approach, as well as the EU approach to incentivizing R&D for antibiotics, the voucher scheme proposal from the European Commission?
Yes. So we had the pleasure of doing some work for the Swedish presidency of the EU Council, looking at this very question. So yes, the UK subscription model is, I would agree with Anthony, it's still in the early phases. So, but nonetheless, still represents the most long-standing efforts to implement a subscription model for antibiotic research and development. Crucially, it's priced at a level that aligns with that work that Anthony was talking about. So the UK is paying its fair share in innovation for what are our best estimates of what size the subscription model needs to be to incentivize antibiotic research and development. The Swedish model is innovative. It's an annual revenue guarantee that's slightly different, where it's not a fixed amount paid for access to antibiotics. It's an annual revenue guarantee where you can, the Swedish government commits to covering any difference between the annual revenue guarantee and what the market authorization holder generates in terms of their revenues. But crucially, it's not priced in the same way as the UK model. It's priced for access rather than stimulating innovation. We've also done quite a lot of work in looking at what incentive could work at the EU level, which is a politically challenging situation, because you need to get the agreement of all of the EU member states to sign up to an incentive for it to represent a meaningful incentive to industry. So there is a pilot for an annual revenue guarantee more aligned to the Swedish model, where it's priced for access rather than innovation. But there has been talk about the voucher, the so-called transferable exclusivity voucher, whereby a market authorization holder that brings an antibiotic to market can extend their market exclusivity of any drug in their portfolio for up to 12 months, or sell this to another pharmaceutical company. But the costs implications of this are very uncertain, and there's obviously equity implications because you're shifting costs to another therapeutic area. So it's been a very controversial suggestion, which you could do a study just on the political economy around the incentives at play that influence different actors involved in advocating for the voucher, but it remains with the European Commission Parliament at the moment and may yet be enacted.
Thank you, Michael. Let's move on with taking some more questions.
So there's two questions that I think I might. So I think it's quite helpful sending you a couple of questions at once, Anthony. So there's a couple here around global collective action. So one which I think will stimulate quite a lot of discussion. So there's we've got Maria from the UK Health Security Agency, who says, has your work considered ways to share the cost of interventions across countries and their willingness to pay for research and development in this area? And then we have another question from Mike Ward, which is, it appears to me that a pan-global response, which sees countries working together to curb AMR, is needed. However, with many countries taking a more inward view, most notably the US, is this option no longer available?
Thank you very much for that. In terms of how to share costs across countries, it depends on what the thing is. If we're looking at interventions like better access to healthcare, better innovation, paying for antibiotics, then the default is that those costs will be borne by the nation state involved. I think particularly for low-income countries, and to a much lesser extent for lower middle-income countries, there is official development assistance that can and does help with that. And I think donors should prioritize antimicrobial resistance as part of that and make sure that the funds are available so countries can take steps to build infrastructure and stop those things. But in general, that can probably all fairly neatly fit into the structures that we have in general. There's nothing unexpected. Where pan-global response makes more sense is that is innovation, and not just antibiotics. There's more that can be done with diagnostics and vaccines, and other non-bacterial, non-antibiotic treatments to treat bacterial. For all of those, if somebody comes up with a new antibiotic in London, as the first one was, like penicillin spread around the whole world. And the same as if somebody comes up with it anywhere. And if the US or the UK government funds it, it's not like we're going to keep that within our borders. So there's a really strong argument for cross-country collaboration. How that's funded, it would almost certainly only be high-income countries that are willing to pay into this. But that's okay. High-income countries are about half, I think a little over half the global economy, and most who are willing to fund this are generally willing to fund their share amongst high-income countries, which is what the United Kingdom does. But it's not a good time for global solutions to global problems. The politics is not there at the moment for that, which makes this hard. There are two jurisdictions that I think are more than big enough to fund this themselves. So if the United States passed the Pasteur Act, which is their version of a subscription model, that's probably enough to really drive the agenda forward and to create the funding in and of itself. The European Union is also big enough where it could do this alone. And prior to June 2016, the private view in the Treasury was that the UK is too small to fix this problem. What the UK should do is to make the European Union take this forward and use its voice within the EU to put this as something that is fixed at a European level. And even then, I mean, the UK was by far the most Eurosceptic country in the EU. The Treasury is not historically a great lover of the EU, though it's not a fan of leaving it either. And yet there was clear to most people involved that this had to be done at a bigger level than the UK. And so either or ideally both of those entities driving this forward would be great. There has been commitments to the G7 and to look at this, but it's hard. The politics is hard.
Thank you for that. So I think so there's a few questions. We'll come back to the methodology for just a while because there's a few questions I can group together in relation to that. So we have a question from Chesney Gina, a recent public health economics graduate. So she was asking about how AMR covers such a broad number of diseases with varying severity and outcomes. So what measures did you take to ensure sufficient granularity in terms of variations in different diseases and antibiotics? And then we also have a question around did you calculate, so was there any assumptions in your model about the use of antibiotics in livestock and if that increases AMR? And then we have a question from Warren Cal from Shinogi and asking about whether the modelling breaks down to regional or country level, because for policymakers in different regions that could be quite helpful in terms of policy advocacy work.
Great questions. So the disease and health part of this was done by the Institute of Health Metrics and Evaluation. We used all of their inputs in our modeling. They took 12 different diseases and I think 15 different antibiotics. Not every antibiotics can be used against every disease, but so I can't remember the combination, but it's something of definitely over 100 bug drug combinations that they modeled forward, and we used that. And IHME data isn't perfect, but one thing that is a real strength of their approach is that they try and standardize results from across every country. And so if you take data from the UK and you compare that to data from France, often they might say similar things, but different things are happening on the ground, or vice versa, because the way UK defines things will be different to how France defines them. And that creates a real challenge in this. But IHME primary goal is to standardize all of these definitions and all of these methodologies so that we get a true sense of, as best sense we can, of what's happening across the world. And that is what they've done in their AMR work as well. In terms of country level data, yeah, we will be releasing country level data for 122 countries. Those countries cover 98.5% of the global economy and 93% of global population. We, as mentioned earlier, we have papers coming out next week, which will include some of those as tables in it. We're also will be releasing a interactive tool where you can see each of those 122 countries in different scenarios and get kind of a more detailed information on those. And that will be coming out shortly thereafter. And then livestock. So we didn't look at livestock because RAND and the World Organization for Animal Health did a separate livestock study. In terms of how much livestock drives antimicrobial resistance, there isn't a perfect study on this or a great understanding of it. It's probably not huge because bacteria that infect animals tend to be quite different from bacteria that infect humans. Resistance in a cow is not going to translate to a human all of the time. And then also, we all meet lots of humans in our lives, but how often do you actually meet a cow? And so the route to spreading is much more contained. So it's I think generally agreed that it's far smaller than its share of antibiotic use, but it's not zero, and more work is definitely needed on working out exactly what that scale is.
Thank you. So there's a couple questions here which are more around, to be honest, it's probably slightly beyond the remit of this piece of work, but you offered some really interesting insights around provider incentives and antibiotic use earlier, particularly from your own experiences in Ireland. So let us know if you can talk more to this topic, because we have two questions where one which is around so especially in countries where the purchaser is not the single consumer but a third-party payer, public, private, or a mix of both. So can you share any innovation in purchasing that can address AMR to align provider prescribing behavior? And then we have another question which is around, to what extent you see educating future prescribers on antimicrobial stewardship as important to strengthen global action against AMR.
I gather the first question will be linked to whether countries link payment systems to targets in terms of antibiotic prescribing, but this might be the topic for another seminar. I would guess it's quite an interesting one.
Yeah, I agree, and I'm probably not the best person to answer it, but it also depends on how much data there is, and so NHS has good data on how much every person every doctor in primary care prescribes. There are other countries that also have very good data, and that allows you to create systems that where people are challenged or asked about, identified who have higher number of prescribers. You can build in rules in hospitals, like where you need clearance to prescribe certain drugs. You see this done voluntarily by certain hospital groups in India, but it's not done at a federal level, or indeed, I think, by any of the states. So it is possible to bring in rules like that. You don't need you don't need to have a fully public sector. The two things that are noteworthy is that the state has the most control in a fully public system. They don't have to generate new incentives in the same way because they're generating incentives for loads of things already, and they're paying the staff directly. And then states tend to have better data in fully public systems because everybody's on their payroll and they're paying for the drugs themselves, and there's lots of reasons where it makes sense to link those up. While if you have to build a bespoke data system to understand what's happening with individual doctors, then it becomes harder. And you need to have that, or it certainly helps a lot to have that individual data, because otherwise you don't have, if you don't know what's happening, it's harder to change it. In terms of educating future prescribers, this is, and a lot can definitely be done here. There's a huge discrepancy between doctors, particularly in primary care, about how much antibiotics they prescribe. There was one study in the UK where about 10 years ago now, the chief medical officer wrote to the 10% of GPs that prescribed the most antibiotics in the UK and told them that they prescribed more, they were in the top 10%, and advised them to prescribe less. And there was a noticeable decline in the amount of antibiotics those GPs prescribed. There's so there's definitely space to do something there as well, but again, a little bit outside my area of expertise.
Mm-hmm. I think that's fair. So there's an interesting question here from Mike Ward. So I enjoyed your discussion around some of the challenges you encountered, trying to think about the counterfactual scenario about what would have happened to the AMR rates had there not been the pandemic. And just building on that, and thinking about some of the reductions in AMR we saw during the pandemic. So Mike Ward asks, what lessons should we have learned from the pandemic when it comes to think about developing protection from AMR?
So it's a good question. There's some simple things that we learned, like people are much more willing to get tested than I think everyone gave them credit for. But it's probably noticeable. It's probably first worth distinguishing the two. And antibiotic resistance is there's never going to be a March 2020 where we go from quite low levels of antimicrobial resistance to very high levels. Bacterial infections spread much more slowly than viral infections do. And while what's happening in places like China definitely matter across the world, they don't matter nearly as much as if a strain of the flu or a coronavirus outbreak happens. And so we'll more get a steady ratcheting up of antibiotic resistance. And that ratcheting up can be quite quick, particularly in one country. You've seen in Italy and Greece 10, 15 years ago, you saw quite large jumps in different types of antibiotic resistance over a 6-month period, but it didn't spread to the rest of Europe in the same way, and it could be contained. So that makes the lesson learning kind of challenging. I often worry that we'll learn the wrong lesson. So in COVID-19, we came up with vaccines very quickly, as everyone is aware. And that's mostly because we had tools in our arsenal that we were developing globally, were being developed for cancer or for other things that it turns out luckily worked very well against coronavirus. Almost by definition, resistance happens when there is no tool in our arsenal that works. And so we're going to have to go back to the drawing board. And while there are definitely ways you can speed up clinical trials, as happened during COVID, a lot of the early stage research that was done in a matter of months for the coronavirus vaccines would take a very long time. So I think that makes it challenging. There are probably illnesses that are better at telling us, like it's more like something like HIV or malaria, where you see this kind of steadily ratcheting in time and everyone's kind of used to it. But yeah, there are important questions on infection control and education that worked fairly well, at least in the short term, from COVID, that we should look at.
Anthony, let me ask you a slightly provocative question now. With the US withdrawing from WHO, will global efforts to address AMR be stalled, or do you expect the US to be more actively engaged through the G7 or G20?
I cannot know for sure what will happen. One thing I'll point to is the largest funder of AMR research in the world is the US government. The second largest funder in the world is the UK government. And the third largest funder in the world is a charity called the Wellcome Trust. So we rely heavily on, particularly on the US and to a lesser extent the UK, to drive this research agenda forward. It's plausible that Trump increases it, and that would be great. I think it's probably more likely that you see a steep decrease than you see a steep increase. And that would create huge risks. it also seems likely that even if there is an increase in funding, it'll be very domestically focused and isolated from the rest of the world, which I don't think is in America's long-term interest, because pandemics that are, fixing diseases that are prevalent in South and Southeast Asia are probably the ones that are likely to become prevalent in the US in the future. But and sharing knowledge and stopping those things at source is probably helpful. Doesn't fit perfectly with the ideology that we have. I think one thing to note about Trump is that, and the WHO, is that it's also just going to create, or it's likely to create, huge problems across the world that also need to be fixed, that our work maybe fairly well at the moment. I won't say where, but a person at a foreign ministry working on health told me in October that they'd spent 6 months wargaming what would happen to global health infrastructure if Trump won. And I asked them if they had any solutions, and they said, no, there just aren't any good things that we can do. There's no country that can step in and fix this and keep the wheels on the road. And so I guess a worry I have is that when family planning things start falling apart and need to be funded, and when other parts of global health infrastructure are taking huge steps backwards, it'll be hard to get an argument for taking a meaningful step forward.
Thank you, Anthony. So we take another question and then conclude
I
the
think
session.
there's one more question here, and then I might add one. I think it's related to kind of just the last one that I wanted to ask. That might be a good way of wrapping this up. So James Stewart asks about, how do you move research to practice on this very important public health and economic problem? And what I'm interested in is kind of the next steps. So, what plans do you have in terms of leveraging the findings of this exercise to advocate for global collective action on AMR?
In terms of our next steps, we've already doing quite a bit to socialize this. There was a ministerial conference in Saudi Arabia that had 50 health ministers out, where they were kind enough to let me present the results. The World Bank is doing an event where we'll present this at. We're quite a small think tank. There's not like we have our finger on the pulse of world leaders, but wherever we can, we are trying to raise awareness of this and the problem. The UK government is the ultimate funder of this research, and they are very much planning to continue to push this forward to raise the profile of this work and this issue, which I think will be good. We are, as I mentioned, going to publish detailed papers that have country level results and an interactive tool, which I think I'm hopeful will kind of draw more attention to this work. And once it's available at a country level and people can see what's going on in country level, I think that will cause greater debate, and hopefully, ultimately, media organizations are almost always based at national or subnational level, and governments make decisions at national level. And so having global results is less exciting than having national results. So hopefully that will drive things forward too. And in terms of us, we're doing some follow-up work as part of a different consortium, which is just about to get underway, which is a project called GAPI, which is going to look at how much antibiotic use can there be in the world, and how do we get antibiotic use down to a level that is sustainable, and what is a sustainable level. And we'll hopefully answer some of the modeling questions, that epidemiological questions that have alluded to earlier and that have made this work difficult. And as part of that, we will be building on to this different scenarios and what the economic returns will be. And so we can have more than just 5 scenarios that we model interventions from. And hopefully that will again be useful to policymakers in terms of how they tackle this.
Thank you, Anthony. With that, we conclude today's session. Thank you again, Anthony and Michael, for your thought-provoking presentations and for engaging so effectively during the Q&A session. I would like to also thank everyone in the audience for your active participation and insightful questions. Your engagement is what makes events like this so meaningful. Thank you once again, and we look forward to welcoming you at future events. Have a wonderful evening, and hope you enjoyed the interactions with the speakers. Thank you so much.
Thank you.
Thank you. Bye.
I know.